Hey everybody, AM 1230 WJOB in Hammond, Indiana. Let's get going here. Hey everybody, welcome in. My name's Jim Deedlow. Welcome into AM 1230 WJOB and 104.7 FM. A little midday health talk. We're going to do that right now with Dr. Sean Kondamuri of Midwest Interventional Spine Specialist. And there he is right there. How you doing there, doctor? All right, you're muted, so we have this. So you are muted.
Like this.
There you
Better?
go, much better. Yes, it's always like a foreign film dub or something when we start out like that. So hey, nice spine behind you, by the way.
Oh, thank you. Thank you. I actually rearranged my office.
Oh, yeah, I was gonna say it actually looks a lot better. You don't have the window behind you now, which is better.
Now the window's sort of like in front of me, so better light, I hope.
Yeah, much better light. Dr. Sean Kondamuri is with Midwest Interventional Spine Specialists, and you guys do what, doctor?
We are spine specialists, so we take care of patients who have back problems, neck problems, sciatica, herniated disc, that sort of thing. But we also take care of all kinds of other chronic pain, like pain from joint arthritis or pain from neurologic conditions like neuropathy, diabetic neuropathy, that sort of thing. And we're here located in Munster, Indiana, Chesterton, Indiana, and also in Dyer and Hobart. And myself and my four partners, Dr. Desari, Dr. Gupta, Dr. Saveen Kondamuri, Dr. Shetty, and my nurse practitioners, Katie and Lisa, have been treating patients here for almost more than 20 years.
Doctor, we started doing this, and a lot of what we talked about was, specifically, some of the spinal techniques. It's gotten, with COVID, it seems like we hit that all the time. Maybe today we'll hit a couple of the spinal techniques, and then we'll pivot over and talking about some general COVID topics, if that's okay with you.
That sounds good.
Doctor, I was looking at some of these newer techniques. Explain what an interspinous spacer is.
Yeah, so great. So interspinous spacers, there's very many different kinds of interspinous spacers, but typically if you look at a spine like this one, and I know I might be on radio too, so the people on radio can't see what I'm looking at, but if you look at the spine is consisting of many vertebrae that stack up on top of each other, and there's these discs between the vertebrae. If the discs are herniated, or the space between the bones is very flattened and there's not much space, what happens is in the back of your spine, you now have less space for the nerves that try to emerge out of the spine. So those nerves are going to get compressed, and it's going to cause you a lot of pain in your back or your leg. So a spacer will sometimes be placed between the bones to separate the bones a little bit and give you room not only in the front, but also in the back, so you'll have less pressure on those nerves. There's another kind of spacer that's used in the back of the spine to lift up these, we call them spinous processes, or little wings that come off the back of your vertebrae, and you can put something in between them to lift it up, also to help take off pressure on those nerves and to treat spinal stenosis.
What are those made of?
They're made of various products. Could be titanium, could be different forms of plastic and metal. They usually do not react with the body, though.
So I see that the metal has been around a long time, but they've been able to put together some newer alloys that seem to last longer, and they don't irritate as much.
They do not. They don't irritate. I mean, that the issue is not really with rejection or irritation of other body tissues. The issue is just that whether they work or not.
How do stem cells come into play with you guys?
Yeah, so stem cells are part of our regenerative medicine algorithm. We have a number of different treatments that we provide that fall under the umbrella of regenerative medicine. And the idea is if your body can use either its own cells or cells that are delivered from the outside into your body, you can hopefully heal faster, especially for soft tissue or joint pathologies. And if you can heal faster, then you can do well. You can improve the cushion that you have in certain joints, for example, if you can help regrow back some of the cartilage. So stem cells per se, actual stem cells, are not really allowed in the US. I cannot give stem cells to a patient, but I can give other products that help your body to develop the same stem cells. There are also other products like PRP, platelet-rich plasma, that I can give a patient that helps them to again, help regenerate the tissues. So stem cells on their own are not allowed right now, although you see billboards all over the country for people who are proposing, who say that they're giving patients stem cells. They probably are not.
I did not know that that was not allowed.
It's not allowed.
Is that across the board, or is it just for spine doctors?
It's across the board.
So
There are products that are like stem cells that help the body to create its own stem cells, to recruit its own stem cells, and I can give a patient his own stem cells. For example, we can put a needle into the bone right here, into this iliac crest, which is a part of the pelvis. I can insert a needle there and I can suck out the stem cells from a patient, and I can give those same stem cells back to the patient. That's allowed. That's his stem cells. But we cannot take stem cells that are made in a lab and give it to a patient right now. That, even though you hear a lot of people advertising that, they're not really doing it. The problem with using stem cells from the patient is, one, it's a little painful to get the stem cells out. That's not that big an issue, not usually. But the other problem is that if I take stem cells from somebody who's 50 or 60 years old, those stem cells are probably not going to be as effective in doing what we want them to do, because they just really are, they've lost a lot of that capacity.
They're older.
They're older. They don't work as well.
Talking to Dr. Sean Kondamuri. If you have any questions about any of this, we are live on the radio, 219-845-1100. Doctor, so if you have to look at like some of the more innovative techniques over the last 10 years, maybe something you did not have at your disposal 10 years ago, what would that be?
Well, one thing that we're really excited about is something called Vertiflex or Superion. And I mentioned that a little bit. In the back of the spine, there are these things that stick out of your spine. And if we can separate them by putting something in them, like this device right here, if we can insert a device like that inside the area between these bones, we can now open that up. It's like a spacer. And that's something that's pretty new. It's only been out like less than 5 years. And that allows us to help treat spinal stenosis. And patients who have spinal stenosis used to have only one option. It was either get physical therapy, medications, injections. And if that didn't work, you had to go and have surgery. But now we have an in-between option for patients who can't necessarily have surgery and who the other more conservative treatments aren't helping them anymore.
So what is physical therapy? I mean, what kind of injections? You still do injections, correct?
Oh yes, definitely. And patients get injections every day that we're working, and many patients do extremely well with injections. That's all they really need is get an injection, get physical therapy, strengthen your core, exercise, continue to walk, but try to exercise 30 minutes a day, 4 or 5 days a week, and you will do extremely well. Some patients, though, have such a severe bony stenosis that they need something more.
So if you were going to go and put it on a like a continuum, somebody comes in with, say, lower back pain.
Yes.
And whatever, that's a woman and she cleans a house and it's hurting her, and so the very first step, and then what would the next step, and then if that doesn't work, what would what are the 3 or 4 progressions?
The first step, great question, Jim. The first steps are going to be conservative care. Anti-inflammatories, maybe give them muscle relaxant, but if in many cases, not even any kind of medications at all, really just activity. If they can exercise on their own, we have them do that. Generally, if they're coming to me, they've already tried that, they're not better, so we may need to get them into physical therapy. So a physical therapist can help to mobilize the spine in a nice way. So if you can mobilize the spine and not keep it so stiff, and also to loosen up their muscles and improve their joint motion, they can do extremely well. Most patients will do well with physical therapy or chiropractic therapy. Actually, a chiropractor can do many of those same things. A skilled chiropractor can do a lot of that himself. So if that doesn't help, the next step would be maybe medications directed towards the nerves. I might give somebody a nerve medicine, a nerve medication to help heal that nerve that is firing in a way that we don't want it to, that's causing severe pain or tingling or numbness. If we can calm down the function of that nerve, it'll reduce those symptoms. And if that doesn't help, and this is assuming all the conservative care that they've tried, like diet, exercise, nutrition, even acupuncture, some of those things have already been tried, and they come to me for medical options. If they are not improved by physical therapy and more advanced medication managements, I would definitely consider them for an injection if it's appropriate. Like if they have a significant narrowing right here, for example, because that disc is herniating into that area, then I'm going to put some medication right in there using a special camera that lets me see into your spine, and the camera will I can focus right on the area where the narrowing is, and I can insert a needle through the skin after numbing the skin. That needle can be inserted right into that area, and very, very precisely, I can get a steroid medication in the area where the inflammation is the most intense. We can take down that inflammation, have them continue their therapy and exercise, and patients do really well.
Doctor, before we go to the next stages, one of the beginning ones is nerve medicine. What kind of nerve medicines and what do they do?
Yeah, there's a number of them. So one of the common medicines that a lot of people might have heard of is gabapentin, or Neurontin is the other name of it. Gabapentin is a medication that stabilizes the nerve membrane. So if you give this to a patient, it stabilizes that membrane, it reduces those nerve symptoms. And that is given to patients either 3 times a day or just at nighttime. One of the side effects of gabapentin is it makes you sleepy. And if we give it to them at nighttime, we can sometimes avoid that sleepiness. The other issue is sometimes it makes people confused, or they can get forgetful and they can have some central nervous system complaints. If they don't have any of those problems, the sleepiness can be easily managed by giving it to them at night. It's a very well-tolerated medicine. Another medicine is called Lyrica, which is similar to gabapentin. Lyrica doesn't cause the sleepiness that gabapentin causes, and it is a really very effective medication for lots of nerve conditions like sciatica or peripheral neuropathy, and it can control this nerve pain very well. Another medication is the old-fashioned medicine called Dilantin, which is a seizure medicine. And Dilantin can do many of the same things that we're talking about here. Another commonly used medicine is Cymbalta. Cymbalta is a great medicine to help reduce the same nerve symptoms that patients have. It's more commonly used for diabetic neuropathy. Cymbalta is an excellent medicine that has a very, very safe side effect profile. Patients don't have many side effects on Cymbalta at all.
You know, you see a lot of these advertised on television, like Cymbalta especially. No sleepiness with Cymbalta or Lyrica, but sleepiness with gabapentin?
Correct.
Cool.
Yeah.
We're talking to Dr. Sean Kondamuri. We're going into some specifics today of some spinal things. So we started off, all right, somebody comes in, you do the anti-inflammatory, you do some physical therapy, you go to Lyrica, Cymbalta, gabapentin, that kind of Dilantin, and none of that's working. Then what's next?
So then we talk about the spinal injections. In spinal injections, if the problem is spinal stenosis or a radiculopathy or sciatica, spinal stenosis or sciatica, an epidural injection, a transforaminal epidural injection is indicated at that point, and patients can do extremely well. If they do not do well with that, and combined with physical therapy, then they might be a candidate for a surgical procedure. And we hope that they're going to get a lot better from this, and many of them do. But if they don't, then we have to escalate a little bit. Then treatments include either the Vertiflex procedure, which I talked about, which is what that device, this is an example of what that device would look like. Or they might even have to go to the other end of the extreme and actually have a decompression surgery done. And that surgery is what is typically called a laminectomy discectomy. And there we're cutting away a piece of the bone, and we're also trimming away a piece of the disc itself. So now you're making space in there where the nerve used to be getting compressed. And that's an option. The difficult thing sometimes, though, Jim, is we have patients who've already had a laminectomy. They may have already had a fusion, and now they're having pain. And that patient's not a candidate for another surgery. Or if they are a candidate, they're not interested because they didn't get relief the first time. So then these patients are sometimes considered for spinal cord stimulation. And stimulation is a very advanced treatment that we are often called upon using in patients who have in the patients who are very severe, who have already had a surgery that has failed them. Or, I mean, you'd be surprised. I have patients who come to me who have had 10 surgeries on their back, and they're still suffering. So sadly, we kind of have to go through the continuum a lot faster and get right to spinal cord stimulation. And that's an excellent option because it does completely reduce their pain. The spinal cord stimulator is a computerized device, and it's a little battery that looks like this that goes into their body. It's extremely thin, and that's placed inside their buttock, in the fatty tissue over their buttock. And this powers like a pacemaker would. A pacemaker usually sits, up in this area here, over your heart. The pacemaker battery is similar to this. This battery powers the stimulator, which is kept in their spine. And that is excellent to reduce their pain. And patients can do extremely well with spinal cord stimulation. But, we don't often jump to this right at the beginning because it's another small surgery. Patients may not want that. And secondly, it's an expensive procedure, although all insurance companies approve it.
not to trivialize this in any way, but what if you're like really skinny and you don't have a lot of buttocks material?
Yeah, so great question. So these are two devices, two different batteries that I have in my hand here. You'll notice one of them is twice as big as the other. 10 years ago, 15 years ago, this would have been considered tiny compared to what we used to put in. It was literally twice this size, thicker than this, and twice the size as far as the width and height. They're getting so small now. I can put this in somebody who's extremely thin and have no trouble. This is. I mean, I don't know how. If you can see my fingers, you can kind of get an idea of how. I'll put it in my hand, how small it is. It's extremely small and very thin, and patients don't even feel it.
All right, so you go in and you insert that in somebody's buttocks, and then it has a wire that goes to the.
Right.
Yeah, explain that.
This is the. It's called the. This is, you can consider this the battery that powers the actual stimulator. The actual stimulator itself are two very thin wires, about as thick as a pen, maybe you could say, the top of your pen here. As the actual pen piece, that's about how thick the wire is for a stimulator. And generally patients will have two stimulators placed in their spine above the area where their problem is. So if their problem is in the L4-5 area, the lumbar spine, let's say, the stimulator is placed quite a bit higher than that up in the thoracic spine. So here's the lumbar spine. The stimulator will be placed back up here before the trouble starts, before the area where the trouble starts. And the wire is placed in the spinal canal with a, it shouldn't, I don't want people to be scared by it because it sounds like it's a scary thing. It's pretty minimally invasive. It's done through a needle. We don't even cut you open for that. We put it in through a needle to get it in. And once it's there, we trial it on the patient. The patients can do really well. And this powers the actual stimulator, which are those two wires, which have they have electrodes on them. They can be controlled with a mini computer in a very complex way to give you the stimulation you need to take away pain in the back or in the legs.
Talking to Dr. Sean Kondamuri, and you know how many people are geeking out on this right now? There are. I mean, you obviously can geek out on it pretty good. You've been doing it for years.
It's very high tech.
You know,
the technology has improved so much. I mean, I've been doing this since I started practicing in the late 90s, and the technology has improved so much. What we have now is so different than what we had years ago. Although I have a patient of mine, I won't say his name, who I saw back last year. I implanted a stimulator in him for a neck and arm problem. And I did that 17 years ago. I put in his device. It was a very old stimulator from those days, a Medtronic device. It was really, by today's standards, it was pretty prehistoric what I put in him. But when the battery died, it actually lasted 17 years before the battery died. The battery died, and then his pain came back, and I had to put a new one in. And he was like, I told him, we have newer technologies. I can put a new type of battery. He told me, Doc, I don't want that newfangled. So give me what I had before. That worked great. I don't need anything else. And I had to search with the company to find his old device, his old battery that they had, so I could give him the same device that he had before.
So you had to like go to the used spinal stimulator heap, and did you get that on Craigslist, or how does that work?
No, it was a brand new one. The brand new one that the company would have. You had to, kind of search for.
Doc, you mentioned, like you've been doing this for a number of years. We covered a lot of ground there. So, how did you get drawn into spines?
Oh, great question. Yeah. So I started out in internal medicine. I did an internal medicine residency in New York. So I had always thought I was going to go to cardiology. That was my dream originally. And then when I was in internal medicine, we would get called for patients who had heart problems or chest problems and things like that. And everybody would get all excited about chest pain because it's like that was cardiac. So that's what I was originally excited about. But then after a while, I noticed that patients complained of back pain and neck pain, and they didn't get any attention. If they had back pain, they'd just give them Tylenol, and they'd be told, just you have to live with your pain. There's nothing we can do about it. And that was about the time that my specialty was really starting to emerge and become big. And then I sought out pain fellowships, and I decided I was going to do a pain fellowship. I thought that this is something that needs to be helped. There are so many new things that are starting to come out for this. Why should people suffer? So I had to do an anesthesiology residency in order to get into my pain fellowship. So I did my anesthesiology residency. Then I went and did a pain fellowship at Yale University. And after that, I full-time treat pain. And that's my passion. That's what I'm excited about doing.
You know, we didn't talk that much directly about pain. I'm going to ask the same question in terms of, like, you know, pain medicine, or I know you got spinal stimulation there, that kind of thing. Any other major advancements strictly on pain?
Well, there's so many, Jim. I mean, I don't even know where to begin. There are so many things happening. Even from a medication standpoint, there are medications that are pretty cool now that we can use on patients. There are also just technologies that are improving a lot. And even older technologies, which we did before, like the stimulator, for example, have improved so much. And the programming is so cool. That the technologies are so different. What we can focus in on. We can focus in on different cells within the spinal cord to help control pain that we never even thought of 20 years ago. You know, so there's just so much going on. That's hard to answer that question unless we focus on one particular thing.
Talking to Dr. Sean Kondamuri. Doctor, you've been riding your bike?
Yes, I rode this morning. It was great. It was 33 degrees this morning when I went out. It was, at first I was like, oh God, I don't want to go out. It was so cold. Then I got myself to go out. I rode for about an hour and it was exhilarating. It felt great. I got so much energy out of riding in that cold weather. It was fantastic.
Any suggestions about protecting your spine and protecting your body when you get out to do the cold weather rides and the cold weather runs?
Yes, just take it slow. I mean, take it slow to begin with. Get your blood moving. Get warmed up. If you can warm up beforehand, that'd be nice with some stretching. But really, just you got to take it slow because you're right on target there, Jim. I mean, your body is stiff. It's cold. Your joints are stiff. You're at a high risk of injury. So you want to just take it easy and take it slowly.
He's Dr. Sean Kondamuri. Doctor, anything about COVID that's happened in the last, I think it's been 3 weeks since we talked.
Yeah, our president is in the hospital.
Yeah, exactly.
That's a big one.
Yes, the president's in the hospital. What would be your concern, just from a general standpoint? 74-year-old man going in that's overweight.
Oh, that's huge. I mean, the fact that he's got two things going against him. One is his age, and two is his obesity. I'm not sure if you're aware, Jim, if you look at all the hospitalized patients, all the patients who have COVID that were hospitalized, 75% of them are overweight or obese. 75% of the patients who get admitted for COVID are overweight or obese. And then if you look at patients who are obese, you're 100% more likely to end up in the hospital if you're obese. You're 75% more likely to get admitted to an ICU if you're obese. You're 50% more likely to die from COVID if you're obese. So obesity is huge. It's a serious thing for many reasons. Being a little heavy, even a little bit heavy is a little risk, but to be obese is a big risk. And obesity is 30% more than the ideal body weight. That's what we consider obese. So it is pretty serious. And it's not, those doctors at Walter Reed Hospital are taking it very seriously, not just because he's the president, of course, but because they know he's a 74-year-old president who's, I think you'd call him almost obese, mildly obese.
I think they're saying, technically he is obese because of the height and the weight. How quickly can something like that turn negative?
Yeah, that's a great question. So right now he went in on Friday. He was positive on Thursday, Friday, Saturday, Sunday, Monday. We're on day 4. Now there was some talk about them trying to get him released today. Dr. Conley, his physician, said we might get him out of the hospital today, and that may happen. It may happen today or tomorrow. He might get out. But every doctor who treats COVID knows very well that in the next 5 days, by day 10, you can literally crash. He could have a severe respiratory event 3 days from now. So that's why in many cases they don't want to discharge you. And if they do discharge you, they're going to give you instructions that the minute you feel like you're having any trouble breathing, to call 911, get into the hospital right away, because it can turn rapidly. From days 4 to 10 are pretty critical. Things can happen where you can get sick.
He is Dr. Sean Kondamuri. We don't want to get scared anymore, so let's end it right now because it's so freaky when we get down into the details of what this disease can do. Doctor,
the reality, Jim, is the vast majority of patients are not going to have anything but mild symptoms, and many patients will be asymptomatic. I mean, I don't want to scare anybody. That's not the goal. But because you asked me about obesity and age, look, I mean, he's in the group of, if you look at 65 to 70, 70 to 75, and 75 to 85, those are the 50% of all the deaths happen in that age group.
Yeah,
Rotation.
I mean, it's just the reality of the situation. Yeah, I didn't really think, you're going overboard with it. I mean, I've interviewed other doctors and stuff, and it's always the same message. It's like, yeah, you could be going along, and then it can turn very quickly.
Yes.
And that, I guess, is the one thing that sometimes catches people, especially people that are used to just kind of being a tough guy or something.
Right.
And I'm just going to tough it out, and it's the respiratory part that gets them. And that's
And
it.
the president have symptoms. It's not like he's asymptomatic. His blood oxygen level dropped from 100 down to like low 90s. And I believe that according to the reports, it happened twice, I think on Saturday or Sunday. And he was given oxygen at least once, maybe twice. And maybe they're not telling us everything. But if your oxygen level is dropping, that means there's some respiratory compromise.
All right, Doc, thanks a lot. Like always, good talking to you.
Thank you, Jim. Have a good one.
All right,
We'll see you.
guys, that's Dr. Sean Kondamuri, and he is with Midwest Interventional Spine Specialists. And if you want to watch this again, it'll be on Facebook, and it'll also be on WJOB Network's app, and just go onto the website. But a lot of information there in a hurry, man. It's almost like a primer on spine. So I'm going to end this video.